Good afternoon, everybody. My name is Leslie Regan. I'm the chair of the charity Wellbeing for Women, and I'm really thrilled to be inviting you, or welcoming you, I should say. More than 300 people have signed up to the platform, and it's part of our Let's Talk series. And today we're going to be talking about Let's Talk Maternal Mental Health. Now, the webinar is going to be recorded, and if you'd like to make comments, please use the chat. Please put your questions in the question box. You've had the opportunity to submit some beforehand. We have a few, but we're very, very keen to try and address as many questions as you would like to place in the question boxes during the course of this webinar. And I'd like to start by thanking you thanks to the Financial Services Compensation Scheme, the FSCS, and to Bolt Burden Kemp, who are supporting this webinar series. And I think it's important for me to also point out to the audience that we're going to be touching on some quite serious mental health issues, and there may be mentions of things that are distressing, such as suicide, psychosis. So you will find in the chat signposts to the NHS website and lots of other relevant support networks during the webinar and in the follow-up. What we usually do with these webinars is take any unanswered questions and any other points listed in the chat. We always invite such wonderfully generous participants and presenters that they usually agree to answer questions that we haven't had the time for, if you like, on air, more leisurely, and we can send you a recording of that later. So without further ado, I'm going to just put a bit of context to this, if I may. So I've been an obstetrician and gynaecologist for 40 years now, a little bit longer, I confess. And one of the things that I think I have seen big changes in is how we manage perinatal mental health. And I want to pay tribute to many of the people who've done so much to raise the profile of this really devastating area of health, which is so often ignored. And I know that when I started as my presidency of the Royal College of ONG back in 2016, one of the first things that I did was to set up a perinatal mental health task force, because I was so concerned about the lack of coordination and communication that often went, or didn't go on, I should say, between the healthcare professionals looking after pregnant women. And we did make big inroads into that. And I think some of you will have attended some of the conferences and the teaching programs that we ran. And although it's not perfect, I think we have made big inroads into improving perinatal mental health services by talking about how important the multidisciplinary team is. And I think that our speakers today are probably going to bring a little bit of that out. I also need to remind everybody, and this is scary, that maternal suicide is now the leading cause of maternal mortality in this country. Now, happily, I can say that very few women die during pregnancy and the postnatal period in the UK, but every single one of those deaths is a tragedy. But for suicide to have become a leading cause is really, really shocking. Also, when we look at those deaths from suicide in the maternal mortality report published last November 2022 by Embrace, what we also saw is that almost every one of those women who died was known to mental health services. So I have to conclude, being self-critical, that we've in some way failed that woman and her family, because of course that suicide affects more than one person. And the other thing that I just wanted to mention to you as we start this, and emphasizing how important this topic is for us to talk about, is how taboo it has been in the past and how important it is that we do talk about it, because what we're also going to be able to demonstrate is that if we can identify those trigger signs or those warning signs or those red flags, whatever it is that you like to refer to in that situation, we can do so much to prevent the problem progressing. And that's what I think we will find from our three presenters today, that we'll see that at every stage along a woman's journey when she has one of these problems, there are opportunities to help her and to avoid it getting to crisis point. And the last thing I shall mention to you before I move on and start to introduce our speakers, or rather I'm going to ask them to introduce themselves with a few key questions that I'll pose to them, is that of those maternal deaths that I was talking about from suicide, 1/4 of them, 25%, were teenagers. And I just find myself thinking, how shattered I would be if my daughters, who are now in their 30s, if they had been a teenage suicide because of their perinatal mental health problems. Absolutely devastating. I don't know how you ever recover from that sort of a loss, particularly I think as a parent and particularly as a mother. So without further ado, let me introduce my three fabulous speakers. I'm going to start off with Abby Easter, who's Senior Lecturer in Maternal and Newborn Health at King's College London. She's also one of the Wellbeing of Women Research Advisory Committee members, so we have much to thank her for, and we already know how valuable her contributions are. And she's also a member of the Institute of Psychiatry at King's. So Abigail, I'm just going to ask you if you'd like to just introduce yourself and why you were so willing to participate in this webinar. Thank you.
Thank you. Thank you very much for the introduction. Yeah, it's really great to be here and delighted to come and talk on this topic that I've been working in now for quite some time. It's something that's very close to my heart, and my research background really is focused on perinatal mental health and perinatal mental health difficulties over the last 15 years. And I think during that time, we've seen quite a lot of improvement in services. So yeah, just be great to kind of talk through and hear from the other panelists as well.
Lovely, thank you. Can I move over now to Victoria May Mills, who's a senior peer support worker working for the Hertfordshire Community Perinatal Team, but she's also has lived experience of this problem, and I suspect that she's going to share with us the fact that one led to the other, but I don't want to take words out of your mouth. Victoria, over to you.
Thank you very much. Yes, hi everybody. It's such a privilege to be here today. So I will be sharing some of my lived experience of postnatal illness. I'm a mum of two. I have two children, a 4.5-year-old and a 2.5-year-old. So it's all still quite fresh in my mind. And I have turned that experience really into my day-to-day job as a peer support worker now in the Hertfordshire Community Perinatal Team.
Lovely, thank you very much. And then can I move over to my colleague, Karen Joash, who's an obstetrician and gynaecologist at Imperial College, Healthcare NHS Trust, and also one of the poor unsuspecting people that I roped into running the Perinatal Mental Health Task Force with me a few years ago. And she's very ably continued with her contributions to that in the annual conferences. Karen, over to you.
Thank you so much, Leslie. Welcome to everybody on the webinar. Just to say, so fantastic to be here. And I think for me, my experience has run into probably a couple of decades of working in perinatal mental health. But for me, the reason why I love it is because I see it as an area where which we can change. And I see the difference in terms of intervention and treatments. I work at the Royal College of Obstetricians and Gynaecologists. I'm running an annual course for development for midwives and consultants and doctors. And also I sit as invited a member of chair for the Royal College of Psychiatrists, involved in the setup of the great perinatal networks and some of the maternity and trauma and loss service, which I'll talk about during the course of this webinar.
Karen. Now, if I may, I'm going to start by talking to Abigail Easter, and I'm going to ask Abby if she will to start by providing some context to the discussion that we're having. So sort of question number one was really to ask to explore with you, what are we talking about when we talk about perinatal mental health? It's a very long word, isn't it? In fact, it can be a bit of a tongue twister every now and again. But let's put this into context and get exactly what we're talking about. Thank you, Abby.
Thank you. Yeah, I agree. I think it can sound quite technical and kind of an unfamiliar term, but when we're talking about perinatal, really just generally it means kind of the time around birth, so during pregnancy, shortly after birth, and in terms of mental health, it's any mental health difficulty that might be occurring during a pregnancy or up to the first year postnatally. More recently, there's been an expansion of kind of services and provision up to the first 2 years postnatally. So I think we're really starting to recognise that this whole kind of window of opportunity and kind of difficulties that can occur during that kind of first year or two after birth. And so many women might have experienced mental health difficulties in the past that can kind of continue into pregnancy. They may become worse during pregnancy, or they may be experienced for the first time. So it's quite a broad terminology that covers things like depression and anxiety, as well as you've mentioned postpartum psychosis and birth trauma. So it's quite a broad umbrella term for any mental health difficulty at that time. I'm on mute.
It always happens once, doesn't it? Thank you very much for making it so clear and apparently so simple. Of course, it is more complicated, but what are some of the common conditions that women are likely to face? Because we've mentioned a couple that are very extreme, if you like, but can you give us a feel for the scale of this problem and also the range of problems that women may experience during this very critical and emotional time of their lives?
Yeah, so as you say, it is quite a broad range of difficulties that people might experience, and we kind of think of perinatal mental health difficulties affecting 1 in 5 women, so it is very common during pregnancy or the postnatal period. Lots of people would experience this to varying degrees. The most common things that people might experience are depression and anxiety, and they tend to be the most common mental health difficulties that we see during this time. I think we often hear about postnatal depression, but actually depression can be experienced through pregnancy, so during the antenatal period. And many people can experience this to quite a severe extent. So we know that a lot of women, up to 50% of women, might experience what's often termed as baby blues, but this tends to kind of quite quickly resolve itself, whereas depression can be quite severe and last a lot longer than that, and result in a lot of kind of low mood. And anxiety is also very common. We've also touched on birth trauma or post-traumatic stress disorder that can be related to traumatic events that are experienced during childbirth or labour. And this can really result in kind of flashbacks, intrusive thoughts. So it can be very distressing for those who've experienced it. And finally, I just wanted to highlight postpartum psychosis, which we've also touched on. This is much rarer, so it's thought to affect around 1% of pregnancies, although it's a very severe, as you've touched on, very severe mental health difficulty that can come on very rapidly within the postnatal period, and tends to be kind of characterised by psychosis and periods of kind of elated mood and depression. And I think Victoria's going to talk a little bit about this as well, but it very much is a psychiatric emergency that would require immediate attention. So as you can see, it kind of encompasses quite a broad range of warning signs that people should be aware of.
Yes, and I think the point I'd like to emphasise, following your very helpful description, is how challenging this is to cater for all these problems, because we're going for something that's very, very common and may affect a lot of women, and they perhaps need some extra support and counselling, to something which is really life-threatening. And as you've mentioned, Abby, sometimes the escalation from the mild to the very severe can be quite dramatically fast. So it's a very challenging area, and I think it's important for our audience to understand that. So would you like to give us a little bit of background, please, Abby, in the common triggers, well, the common causes, and then the triggers, and also whether you can identify risk factors, because for the healthcare professionals on this call, it would be useful for them to know whether there are individuals with a particular history or characteristics that should act as red flags.
Yeah, I think that's really important. So like mental health at any time, we know that there's not a single cause for mental health difficulties, and it can be quite difficult to distinguish early on. But I think there are some risk factors that might increase the risk for some women, and these particularly can include kind of a past history of mental health difficulties. So if you've had mental health difficulties earlier on in your life, you may want to start planning early for your pregnancy, your mental health and well-being during your pregnancy, if you're known, because that can increase the risk of having mental health difficulties in pregnancy, particularly women who've experienced a history of postpartum psychosis, either in the previous pregnancy or if they have a family history, for example, that can very much increase the risk in a current pregnancy. So those factors. And then we know that there's other factors such as early childhood experiences, social circumstances, for example, stressful life events that might increase your risk of depression and anxiety. So really it's about those kind of check-ins with healthcare professionals that people have routinely throughout their antenatal and postnatal care to think about the individual circumstances and the difference, because they can be experienced very differently for different groups of women.
So once again, all sorts of challenges for healthcare professionals and for individuals to recognise their symptoms. So it is a complex area, and I'm very grateful to you all for coming to help us work our way a little bit through it. So Victoria, can I turn to you now? I think you're going to tell us, or share with us, I should say, a little bit about your personal journey. So please feel free to take it whichever way you'd like it to go.
Thank you very much. Yeah, I just thought it would be hopefully useful to share a little bit about my personal experience of postnatal mental illness, to sort of give everything that we're talking about today a bit more context, hopefully. So as I mentioned, I have 2 children, and I had my first in 2018. Gosh, I always forget that. It's terrible. It's all a bit of a blur. And I had a fairly straightforward pregnancy, although thinking back, I probably was quite anxious through it. I had a history of depression and anxiety and quite a serious mental health crisis a few years before getting pregnant, which involved being supported by the crisis team and having quite a lot of therapy and things afterwards. So I knew at the back of my mind really that this could be a risk for me. This could be quite a risky period of time again, but was really optimistic and felt like I'd done a lot of work and a lot of preparation to sort of stay well. And I'd had also 2 pregnancy losses, so that was something else that caused quite a lot of anxiety through my pregnancy, and a lot of kind of catastrophizing, quite a bit, being very, very aware of my baby's movements and things all the time. But generally a really straightforward pregnancy. At my booking appointment with my midwife, which normally happens, some of you may know, at around 8 to 10 weeks. It might have changed a bit by now, but that was the timeline when I had my first baby. When your physical kind of health history is taken, your mental health is asked about as well. And so my history of previous depression and anxiety came up then. And so I was automatically sort of referred down a slightly different pathway for management in pregnancy. And so under the care of the community perinatal team at that point, but it was all very light touch. And also my pregnancy was then managed by a mental health specialist midwife. But to me, this was all just, names on a bit of paper, and I really felt I wasn't going to need any of this. And I think perhaps that was a little maybe naive, and but I like to think maybe optimistic. I had my son, and it was a quick delivery. It was fairly uneventful, other than it being very quick. I was very, very lucky. I'd done a lot of hypnobirthing and things. I think that's always been something that's helped me. And I just really felt like having a baby was going to be the thing that really completed me. I'd had a history of childhood trauma, and so, always working towards this kind of happy ending was something that I tended to do. So there was quite a lot of pressure, I think, from the start with, for having a baby, and that kind of bringing me this real happiness and completeness. And things escalated very quickly for me after the birth of my first child. I was quite determined to breastfeed. I really wanted that experience. I'd read a lot about the benefits of breastfeeding, and I hadn't ever considered that it would be difficult. It's, I think, quite a classic, maybe first time mum thing, and I went into it wholeheartedly. And it was really, really hard, and my baby wanted to feed a lot, and it was very painful, and I was awake all of the time, and I could feel my anxiety sort of really building, and the sleep deprivation really fed into kind of the anxiety rising, and any points that I could sleep, I found I was kind of watching my baby, and the whole thing just sort of fed into this vicious cycle. I do have a really supportive husband. He's still around. But because I was really fixated on breastfeeding, there was not that much he could do to support at night, because I didn't want to express or anything. I felt that skin to skin feeding was the way I wanted to go. Very quickly, because of the sleep deprivation, I now know things felt like I was sort of looking down at myself quite a lot, almost like a quite out of body experience. I couldn't really fathom, like, my thought process was very delayed. I felt like I became quite withdrawn. I would have quite intrusive thoughts that were not psychotic, but were definitely characteristic, I think, of high levels of anxiety and sleep deprivation. You know, this sort of narrative telling me that I wasn't good enough, I wasn't doing a good enough job, don't sleep, that makes you weak, you need to look after the baby, etc., etc. My husband, he's a first-time parent as well, so I think he didn't know, you know, really what was normal and what wasn't. And we were around that kind of baby blues time of kind of between 5 to 10 days where hormones are starting to really lower and change, and everyone's very tired. And so I was seeing midwives and health visitors, but it was not, because I presented as very sort of coherent and very together. It was really, really hard, I think, for health professionals to pick up on what was going on. And because of that, it wasn't escalated to the community perinatal team because I presented as quite well. And that's where I think sort of that information for partners becomes quite important, because they become sort of the eyes and ears for you when you're not able to do that for yourself. Within 2 weeks, things became really, really challenging. I wasn't eating very much. I wasn't sleeping at all, really. And I was not enjoying being a mum. And that really was the biggest disappointment to me, because I thought it was going to be, you know, this really profound positive experience. And things really came to a head one night when I had been feeding my son he fed for a really long time. I now, compared to my second, know that that's not always the case. But he was feeding 45-50 minutes and falling asleep for 20 and then waking up again. So I was never able to sleep. And this one particular night I remember quite vividly, because he'd just woken up. And I just thought, I can't do this anymore. I have failed and I need to leave. I need to not be with my baby anymore. He needs to be looked after by someone else. I am the worst person for him. And I sort of, the thought about killing myself came to me quite rationally. I have had these thoughts before, so they've almost felt quite familiar and comfortable. And I know that might sound really unusual, but I think if you've experienced that before, sometimes there's a comfort that comes from knowing there's a way out. I mean, in a depressive state, not day to day. And so I woke my husband up quite hysterically then by this point and begged him to take the baby. And I ran out of the house in the middle of the night in my pajamas. I couldn't tell you if I had shoes on or anything, actually. And we lived off quite a busy main road. And I just had this overwhelming thought that I was just going to run into the road and hopefully end my life. And ironically, I guess I had not seen the road in the middle of the night for some time, but it was quite quiet. And I think that was, I laugh about it now, because I think, what are the chances? I had this plan, and I'm really grateful for that kind of small mercy, because I really don't believe I would be here today. And I went home a few hours later, had obviously caused quite a lot of worry. My husband had called some of my family, and people were looking for me, and they were about to call emergency services. And I just remember walking in and going to bed like I just shut down. And I don't really know what else happened that night until the next morning, when my husband had to feed our baby formula, because I think I just totally given up, and was just thinking about, okay, how can I end things? That didn't work. And I think sometimes that's kind of there's a moment maybe between when you're about to, you really seriously want to take your life, and then maybe a bit of a gap, and that maybe is that time of opportunity for family members or health professionals to sort of notice that this is maybe where we can get in and help, if possible. So for me, it was really difficult for my husband, because he said to me, we need to call the perinatal team, we need help, something's really wrong here. And I felt really angry at him. I felt like he was betraying me. I told him that, if you call them, our marriage is over, how could you do that to me? All of these sorts of really quite irrational things to say, and it was incredibly difficult for him, because he could see that this was really, really scary and something was really not right, but also he felt he needed to be loyal to me and think about our baby and what was best for him. It's a really difficult situation, and he did call the perinatal team, because I think we were, I don't know if this makes sense, but I think we were lucky to have had a mental health crisis with me before, because he knew that actually this was serious. Whereas if you've not been in that position, and hopefully, you've not, it's very hard to sort of tell. And so it was from that point then I was able to access more services, and kind of start a road to feeling better.
Well, what a story, and thank you so much for being brave enough to share it with us. It's really quite heartrending, isn't it? And as you rightly say, that if your husband hadn't had that prior knowledge of how you access help, it might have had a very different ending.
Mm-hmm.
So if that main road had been full of lorries that night. So yeah. I'm glad that both events happened in that particular way. But I'm just going to move on to Karen now, to ask Karen if, in the context of what Victoria's shared with us, what you would say, what clinical support and treatments are available to women, and then we'll go on to talk about when and how they should be aiming to seek help.
Thank you so much. I mean, that's always really, really enlightens us to sort of the triggers when we look at different things along our pathway, our history, that alert us to the fact that we may need more support. We really strongly feel that mental health is the same as physical health. It shouldn't be something that's taboo. It highlights stigma as well, in the way that people are still, reluctant or worried about talking about mental health. And so when we come on to the treatments, I always think of them as probably four. One is thinking about how do we treat ourselves as a society? How do we get rid of that stigma? That's one part of it. And I think today is going a long way to doing that, getting the messages out there. Fantastic charities like Wellbeing of Women, and there are other charities like Maternal Mental Health Alliance, also the Nest Club, there's Panda's charity, postnatal illness charities that are going a long way to breaking the stigma. So that's one part of it. The other thing that we come on to is that we're thinking about sort of the pillars of talking therapies. Talking therapies are an excellent way for us to really start to engage with what sort of thoughts that we have. Are there things in our mind that's saying that to be a perfect mum, you must breastfeed? To be a perfect mum, you must stay up all night with your baby. These are thought patterns which are unpicked by talking therapies, which are available via IAPS, which is essentially the psychological therapies open to all women during pregnancy and afterwards, and you can self-refer and usually should receive a response within 2 weeks. And talking therapies are also available by the maternity and loss service. Again, a new service which, again, from the story we've heard, triggers of previous miscarriage, where you can actually speak to people and talk about other experiences that may impact on your current pregnancy, that start that sort of, unfortunately, that cycle of anxiety, how you break it. That's one pillar, talking therapy. The second pillar is medication, and medication is really very useful normally prescribed by a team of psychiatrists under the Perinatal Mental Health Team. And there are networks available across the whole of the UK. There's been a fantastic uplift in services over the last few years, so that women should be able to access support from a psychiatrist in combination with a specialist midwife and specialist nurse team throughout their pregnancy and beyond. And they would normally be able to guide about medication, safety.
Oh dear. Poor Karen's in a clinical environment, and the Wi-Fi is not good there. Well, hopefully she'll come back to us. But whilst we're waiting for her, here she is again. Well done, Karen. You're back with us. You were just about to say about when and how.
And I was just back now. So just before I think it might be. Can you hear me now?
Yes, if I were you, I'd keep your camera off for the time being. Not that we don't love looking at you.
Yeah,
that might help with the bandwidth.
Correct. So again, so the next thing is talking about medication. So some women are worried about it, but these teams are really specialists to understand what is safe to carry on in pregnancy and what's safe to carry on while breastfeeding. So really, really good sources of support.
Lovely, thank you.
And then the other thing and then the last thing to consider, I think, is lifestyle measures. So really talking about things as it's described, like hypnobirthing, so mindfulness, things that help with the stress response, understanding about the value of exercise and nutrition, like good vitamin D levels, which help with serotonin. And so, and there's lots of good healthy advice. You can get those from your midwife or your obstetrician just to guide you about what to do in pregnancy.
Great, thank you, Karen. Really, really helpful. So, Victoria, you were going to, I think, share with us a little bit about what support looks like in practice and your own journey to recovery. And if appearances are anything to go by, it was a pretty remarkable recovery. So that's lovely. We can all celebrate that with you. But tell us a little bit about your journey to recovery.
Yeah, I mean, in some ways, I feel like I'm still kind of on it. As I said, my eldest is 4.5, my youngest is 2.5. So, you know, it's not been that long, and sort of some of that, I guess my journey has been started before having children because of being unwell before, and since then I've become more aware of myself and sort of less embarrassed in admitting some of the things that are my triggers, like I need sleep. I know everybody needs sleep, but I really need sleep, and that does not go well with having a newborn baby. And so with my second child, I just knew that I could not exclusively breastfeed. I would become very unwell again. And so I have been able to access kind of support with breastfeeding. I did that privately, if I'm honest. It was through a lactation consultant to kind of come up with a combination feeding plan, because I knew that I wanted to breastfeed, but I wasn't going to be able to do it exclusively. So just a general kind of awareness of the things that are triggers for me. I have been helped hugely. I've been really fortunate with the services I've been able to access. So through the community perinatal team, they, in that first sort of instance, managed my risk within their team. It was recommended that I should have a admission to a mother and baby unit, but after visiting, there were parts of the environment that were definitely more triggering for me. And so the community perinatal team managed my recovery at home, while things remained unchanged and weren't deteriorating. And so through them, I had support from a parent infant practitioner, they're called in that team, but others know them as nursery nurses. So lots of support with understanding my baby and their cues and things, and just building confidence as a mother. I received support from the team psychiatrists. So I was placed on medication, and that was a real collaborative sort of conversation, because I, like Karen mentioned, I was very, very, very hesitant to start medication. I was really worried about the impact it would have on me. But it meant that the second time around with my second child, I was aware that this really did work for me, and so started to take that in pregnancy to hopefully not necessarily prevent another mental health episode, but if I did become unwell, it would be possible that if I was to increase my dosage, that would take effect more quickly for me. Because otherwise it took about 6 weeks really for it to work the first time. And when you are having a severe kind of depressive episode, that's quite a long time. And now I suppose I live and breathe my job really. All the advice I give to the mums that I now work with, I try and take on board myself. I try to eat well. I do still love chocolate. I'm not going to sit and pretend that I don't, treat myself with all of those things. But walking, mindfulness, like all of the stuff you hear that just takes effort to do, I really believe has had such a kind of massive impact on me. And also being a peer support worker now, kind of really using that really difficult experience to do something really worthwhile, because through my recovery, through my postnatal recovery, really, that was what was missing for me. Other mums to talk to that could, you could say, this is really hard and it's not very enjoyable and I'm really sad. And they would say, yeah, me too, because that's not the common kind of message. So yeah, that's kind of all of the things that have helped me.
So was the move to the new job, if you like, and the new occupation in life, was that a sudden thing or was it a gradual thing? I mean, did you have a light bulb moment, or was it just a quiet progression towards it?
Sort of a bit of both. I mean, before having children, I knew mental health was an area I felt really strongly about, and I'd started to kind of do things within my current workplace. And then when I first accessed the services of the Community Perinatal Team, they'd only just really started. So I think they'd been up and running about 6 to 9 months, and there were only 13 of them. And so I got to know most of the team really well and thought, gosh, I would really love to do this. This feels really, really important. And that's when it started. So then when they actually got some funding for it, it was a bit of a no-brainer. I just knew that this was like my calling. I feel like I've been quite cheesy on this talk, but it was another kind of one of those moments that the stars kind of aligned.
Lovely. Well, thank you very much indeed for all of those insights that you shared with us. It's really, really helpful. And I can see by the comments in the chat and the questions that a lot of people are resonating with that and are very appreciative. So what I'd like to ask our audience, rather our panelists, in general, we're not going to let the audience come in just at the moment, but you will have your time, I promise you, audience. But how can we, you, people be aware of or manage risk of developing perinatal mental health problems? So, Abby, would you like to start off with that, and possibly Karen join in a little bit as well?
Thanks. Yeah, it's a really good question, isn't it? And there's quite a lot of different layers to kind of managing mental health. And Victoria's spoken a bit about how that's worked for her. I think, it's about, where possible, early planning. So, if you know that you have a mental health difficulty, talking early about it, either to your GP. We know that talking to perinatal mental health specialists is really important. And I noticed in the chat there was a question about medication, and again, I think the importance of kind of thinking about your medication. If you're taking medication, not suddenly stopping medication, but actually having a proper review with a perinatal team. Many of the perinatal teams offer now preconception care advice, and so if you can talk to your GP about whether those services are available in your area, I think that early planning to manage the risk is important. But then it's also about kind of looking out for these warning signs. So being aware of your warning signs, whether they're kind of a lack of sleep, which is often something that can really trigger mental health kind of to get worse, and kind of those stressful situations. So it's about kind of recognizing the signs of when things are getting worse and accessing different levels of support then during that time.
So you've really rather answered what was going to be my next question, and can you preemptively put things in place? So as you were saying, if you're looking out for the red flags or the triggers, then that might be possible to do that. But it raises another question that I often hear from women I'm talking to, and that is, you said go and find out from your GP whether these are available in your area. So what if I'm your GP and I say they're not available? What do I do then?
I think that's very challenging. And they are expanding, so most areas should have some layer of perinatal mental health care now, at least in community teams. The thresholds can also vary because like many services, they are underfunded, so actually accessing them can be quite difficult. But gaining that support from your midwife, your GP, it can be very difficult to kind of advocate for yourself, and that's why peer support can be really helpful in kind of helping you advocate for different areas of care when resources are.
And 2 and 3 voices being better than one. And Karen, can I bring you in at that point? So what because you'll see patients or ladies who come from elsewhere where they haven't been able to get services. So what's the best thing to advise them? I mean, what's out there if you can't get local support and you don't have a peer group?
Yeah, no, really, thank you for raising that, because actually one of the connections that our social network, the support we get from other women who've been through similar experiences. There are a couple of charities that probably I would like to signpost you to. One is the Tommy's charity, which does have a helpline where you can call and speak to somebody. Pandas also has a helpline where you can call and speak to somebody, and also Maternal Mental Health Alliance. And there are a few charities that exist to provide that support for perhaps where women are falling slightly between the gaps. And they will really be helping to for you to understand about your triggers, your responses, but they do have trained people who are able to talk about mental health challenges to speak to you, and that will give you a little bit of a sort of buffer before you can get to your usual mental health services. If you do, however, feel that you have deteriorated and really need support, we would suggest going to A&E if you're feeling suicidal, or you're still having thoughts of self-harm, or you're really having sort of violent ways in which you might think about wanting to end your life. Really, really important that you seek out help urgently. And so those are sort of really good sources of support if you can't get that. Coming back to prevention, because I know that we've just talked mainly about women who have pre-existing mental health illness. We know that 1 in 4 of us, maybe 1 in 5, will experience perhaps sometimes a new onset mental health illness. So prevention strategies, which people probably haven't recognized the value of, include things that was just discussed now, like mindfulness. We know that simple deep breathing can help to reset the neural pathways around anxiety and really allow you just to think in a slightly different way. We know that walking does a similar thing. You see the brain completely changes. We know simple things like probiotics change the gut microbiome, very linked to moods because of the serotonin that's made at the gut interface. So therefore, we know healthy eating also can help and go a long way. And the other thing I would often say to women when I talk about mental health is to really find a good course that gives you realistic expectations about birth and delivery, as well as understanding the things that are really good, understanding the things that are challenging. So it's just interesting, hearing sort of the talk about the early 14 days where you were essentially in the room breastfeeding, that a lot of women don't realise that them doing that, even that they're not necessarily going to be happy, because nobody's happy losing sleep. And then even if you're not happy, doesn't mean you're a bad mother. That's a transition time. So really helping people to understand the transition points and understand when perhaps their mood is not within the norm, when the baby blues are lasting a little bit longer than they should do, so that they can seek early help. And when you understand about seeking early help, knowing that it prevents a sort of a decline into a pathway which sometimes is unnecessary, that is also another preventative strategy.
Thank you. So as you're talking, I was just very interested in the probiotics bit and also the vitamin D. I mean, is there anything that vitamin D doesn't resolve now?
Yeah,
we take so much that when they bounce us up and down, we rattle. Yeah, very good.
There's also another one I've come across recently, which is choline as well. So choline is a new B vitamin, and it featured in quite a lot of research on the perinatal conference that we did, looking at mood disorders in mums as well. It's linked to people use it also in brain injury, but we know it affects cognitive memory, processing and speed. and it can be quite a big impact. We know, unfortunately, 75% of breastfeeding mums are deficient in choline. It's spelled CHOLINE. And I think it will become the new vitamin D, where we found out about it because of pregnant mums and rickets with babies. And I think with choline, it will be a similar thing, that we'll realise the rest of the population are deficient in it as well. So it works for menopause, dementia, everything. But yeah, there you go.
Wow. Okay, so I'm going off script now, Karen, but you're obviously knowing about this. So where is, fresh from the perinatal conference, what do we find choline in our diet? Sorry, we can't hear you. Okay, well, I'll move on then. I'll move on to our audience now. Perhaps Karen will come back to that in a moment. So thank you again to Abby, to Victoria, and to Karen for their lovely insights. And I'm going to ask our audience now for the queries that they would like to specifically raise. One of the things that I think is coming up an awful lot in the chat here and in the queries is the importance of breastfeeding. And I was going to say to our panel, are you aware of any examples of women who have perinatal mental health crises for whom breastfeeding hasn't made a contribution? Because it seems to always be a factor that tips people over the edge, and whether it's the worries about being not a good mother if it's not going well, and it's hard work breastfeeding. I remember it vividly when I had my twins. But or is it that there's something more fundamental about it that is linked to mood and to perinatal disorders? Abby, perhaps you can take that one.
Oh, sorry, it's Karen. Is it okay when I come in here?
Yes.
But yeah, I'm quite passionate about this as a topic, personally, because I think people feel the benefits of breastfeeding are related to skin and must be solely around breastfeeding. But actually, if you're looking at the breast milk, it's the rich probiotic within it that also helps and provides sort of strength to babies. And we now know that we can give probiotics in the form of a supplement to babies. In fact, lots of neonatal units do that, so they will get that immune benefit. We also know when it comes to skin, that actually should be done with all different family members who are close, because it's the skin microbiome that transfers onto the baby that again gives that baby really good sort of immune health. So it's not solely the mum that the skin to skin needs to occur with. And so in terms of, again, with breast milk, to make good quality breast milk, ideally women need rest, they need nutrition. So sometimes, even if they're having to mix feed, the times when they do breastfeed, that milk will be of higher quality because they're able to get that rest and the strength, rather than being an anxious mum or depressed mum who's having to continually feed every few hours. We know sleep really, really important for bringing down that anxiety sort of axis. So over to you. I think you're about to talk.
Okay, no, that's lovely, thank you. And Gronya Glancy in the chat has helped us out with the dietary sources and given us a link to Harvard. But richest sources are meat, fish, poultry, dairy, and eggs. So thank you for that. Abby, what about you? You were going to chip in, I think, at that point as well, weren't you?
Yeah, I mean, I completely agree with everything that Karen's just said, and I think it is quite a complicated issue where, you know, there's a lot of pressure on mothers to breastfeed, but if you're lacking sleep and having to breastfeed, and then stopping breastfeeding can, you know, make you feel that you're not doing the best for your baby. So I do think it is a very common cause of anxiety and contribution to mental health difficulties. So the importance of kind of having that support and being aware of alternatives.
Yeah, and there's a couple of comments as well about antidepressants, and I'm going to stick my neck out here because I'm no longer a active perinatal obstetrician, but I really do think when it comes to antidepressant medication, what we've got to do is weigh up the risks and benefits, not have a rigid rule. And certainly to the lady that's requiring, Shannon Turnbull, it's not advised that you shouldn't be on them at all when you're trying to get pregnant or when you've become pregnant or during the perinatal period or during the pregnancy. So if you need those to help with your mood, then I think that most of our experts here today would agree that the benefits can many times outweigh the risks, and the risks are very, very small. Anything further you'd like to say about that, Abby? I'm rather encroaching into your territory there.
No, not at all. I agree. I do think it's important to be able to have those conversations or review medication, but stopping medication very suddenly can often be more dangerous than.
Absolutely. Okay. Lovely. Okay, thank you very much indeed. So that was really helpful. Now, there's questions as well about impact on partners and what partners can do to support. And I do have many recollections of partners asking me that, well, what can I do to support? And of course, Victoria illustrated how beautifully in her story that if it hadn't been for her husband and his previous experience of how she'd responded, or how she'd been in terms of her poor mood, he may not have been in a position to help. So what are those, what thoughts have we got from our panel or from the audiences as well to oppose about partners, and what support partners can offer, and what support we need to offer those partners too? Victoria.
Yeah, I'd like to jump in. There's a couple of things. I think I was really fortunate, like I said, with my husband and his experiences before informing my postnatal experience, but there is a sort of aftermath that comes with all of this, and much of that I think falls to how the partner feels after, or family members indeed. So much of the focus at that time is around the mum and the baby, and partners are left afterwards, I think, with a bit of like, gosh, what was that? You know, we've really been through it. And there is still a real sort of gap in supports for partners. So I think that as almost a preventative measure, especially if you know that the mother is at risk of postnatal illness, that as a partner, having support around you, accessing peer support groups. I know that some charities run peer support groups for partners. Local family centres, of course, is now that they run for dads to be or partners to be. I think having access to your own support, their own support network, can really be beneficial, because it's really hard work kind of being that person that is going to be first in line to spot when something's going wrong. And I think it's really different as well from having a first child to having a second. There's only 3 of you most of the time the first time around, so there's more time to focus on the mother and what's going on. And the second time it was different. There's a toddler or other children, or subsequent children that the partner is more focused on. So I think that it changes the sort of support that both individuals need.
Yeah, thank you. And I suppose to add to that as well, there must be a real worry in a partner's mind about, are they being rejected? Perhaps they already feel a little bit rejected because there's a baby was taken up their place, but then there's nothing they can do to help. So I think there must be feelings also of guilt and helplessness. Do you not agree?
Yes, definitely. I think for us, actually, what was quite complex was that I was so unwell for a period of time that my partner really had to step in and do most of the care, and that left him feeling sort of uncomfortable, feeling like he was taking something away from me, and then me feeling quite resentful that I wasn't able to do it, and he was getting all of this, he was getting it right, and he was being the main kind of caregiver. That was supposed to be me. So it's a really complex time in a relationship, that relationship amongst all of you, as you become parents and you learn how to do that, and as you become a couple that are now parents. And so lots of kind of, I think I'm lucky in our service, we have a family therapy support team. So now families coming in that need that kind of support, that is available for them, but it wasn't available when I was unwell. And I think it would have been hugely beneficial, because some of the sort of upset and difficult feelings definitely carried on way past that postnatal sort of period that we've had to unpick.
Lovely,
he's probably going to kill me for saying all of this, probably.
No, I think he'll be very proud of you. And then Nordia Powell has contributed in the chat to everybody. Dads Matter is a great service for dads. So I'm sure that if you were to Google that you'll get some help. Now, last question, how can we reduce barriers to people accessing the right care and support? What's the key to this? I expect there are lots of different ways, but what would you select as your first, Abigail? And then I'll go on to Karen quickly to ask you.
It's a difficult one. I think, I think events like this actually are really helpful. So I think raising awareness and talking about it, because one of the things we often hear is that women feel that they were the only person to be going through this. And actually it's very common. So I think the more we can kind of raise awareness and talk about it, that's going to help. Barriers at different levels.
Karen, just a one-liner from you, please.
I think sometimes it's us as professionals that people feel we don't really care, or that we haven't got time. You're worried that we are busy. We're never too busy for you. Please stop us if we're not asked you. We're not listened. Just say to us, "I really need your help," and we will listen.
Lovely, thank you, Karen. Really, really helpful. And then there was a question, or several questions right at the very beginning. So I must just quickly air them before I wrap up. And that is some of the women on this platform are talking about the cultural barriers that they've met in being able to express it either to their family or to healthcare professionals. Are there any tips of advice from our experts here about how we can deal with cultural issues? Or I suppose cultural attitudes towards mental health problems, but particularly perinatal mental health. Karen?
I do think actually, if it comes to from us as professionals, we see women within a different cultural context, it's really important for us to just say, I may not understand what you're going through, but I'm here to help. If there's anything at all, I'm here to take care of you. Because women are often scared to speak up because they think that their babies are going to be safeguarded or taken away. We haven't really spoken much about that, but that's more prevalent within sometimes different cultural contexts as well. Sometimes they may express some of these mood disorders or feelings in a slightly different way. It may be more physical. It may be that I'm very tired, there's something wrong with me, I don't know what it is. And these are all things that we just need to take time to discuss and to ask again, and to be, you know, just very present with that woman and really just take time to connect. And I believe that with that we can reach people no matter where their background is from.
Thank you. That's really, really helpful. And I'm so glad you've made that point, as you'd have, about the bits that we have missed out. So really, really amazing comments and insights and wisdom from all three of our panelists. Thank you very much again. What are my take-home messages? Well, I think one of the take-home messages for me in listening to you all and looking through the chat and the questions as well is that it's really important when we're dealing with perinatal mental health to acknowledge it and to give individuals, or women I should say, and healthcare professionals an opportunity to discuss it. We've got to make sure that excellence or perfection don't become the enemy of good or good enough, because often it's good enough what you're doing. You can't be a perfect mummy or a yummy yummy all the time. And the cultural experiences and the guilt and the stigma are really, really tricky to deal with, but it's not doing a good enough job. I think must be so hard. I know that I struggled with breastfeeding twins, and I really did think I was a complete failure in life, when actually it was quite a feat delivering twins that came out fine. And also I think something we haven't had an opportunity to talk about was the one question right at the beginning of the chat, a woman talking about how she recently heard that her mother, who is now deceased, had very, very severe postnatal depression, and she never knew about it. And it started me thinking, I wonder if that's because as a mother, if you're very depressed, you don't want your child to think, oh, I've hurt my mum, because children, of course, can be very impressionable and are very, very privy to feeling that they are the cause of problems in family dynamics. So what a richness of discussion and thoughts, as everyone on the platform can, I'm sure, appreciate. Very, very complex issue, very, very prevalent. It's very common, and we must do so much more to try and make those women who are suffering from it, a large proportion of women, in fact, finding it much easier to discuss and also to seek help. So I hope that you've all enjoyed the webinar. As always, it will be available on YouTube in the next couple of days. We'll aim to answer any other questions. And the wonderful Wellbeing of Women team who run these webinars will be sending out resources, lists of resources to everybody who's registered by email. So even if you weren't able to attend today, you can look out for the video, or the film, I should say, and also the resources. So please join me in thanking Victoria and Abigail and Karen for a spectacular webinar. Thank you so much. And I'm going to say goodbye now, otherwise I'll get shot if we run over. Bye-bye.